Welcome, and thank you for joining us today as we embark on an important mission to change the conversation about primary care. As we start to dig into why primary care is the foundation for rebuilding our national healthcare system that unfortunately is failing to meet the demands and expectations of patients and the country. My name is Dr. Bill Wolf. I am the moderator for today's briefing. I currently serve as the Chief Executive Officer at Central Ohio Primary Care. COPC is the nation's largest independent physician-owned primary care group. I'm also the current board chair at America's Physician Groups, so naturally advancing primary care and moving into value-based contracting is paramount to what I do every day. I also serve on the board of directors at Agilon Health. Agilon is a founding member of this newly formed Primary Care for America coalition. At Agilon Health, we are transforming healthcare for seniors by empowering primary care physicians to focus on the entirety of patients' care and thus their health. COPC is proud to be Agilon's founding partner in their initiative to change primary care for seniors. As a leader in primary care delivery for over 30 years, I am honored to be here today to lead our discussion on transformative changes in primary care infrastructure. Our agenda today will be as follows. We will briefly introduce Primary Care for America, our new coalition dedicated to spreading the word about the importance of primary care in driving better healthcare access and better healthcare outcomes. We will start by introducing our panel of speakers, Dr. Asaf Bitton and Dr. Molly Cooke, who will discuss the key findings from the May 2021 National Academies of Sciences, Engineering, and Medicine, NASM, the report and what they mean for the primary care infrastructure. We will then hear from Congressman Raja, who is a member of the Primary Care Caucus. Then we'll share some additional details on Primary Care for America's work. Before I introduce our speakers, I'd like to provide just a brief overview about who Primary Care for America is. Primary Care for America is a diverse coalition of key partners focused on educating policymakers and health policy influencers about the value of comprehensive, continuous, and coordinated primary care. Primary Care for America's formation serves as a commitment to our continued effort to help improve the health and well-being of everyone in America. We know there are challenges ahead of us, and we are dedicated to being a voice for millions of individuals, families, and communities that we serve. We would like to take a moment to thank our founding partners for answering the call and joining us on this journey. They are the American Academy of Family Physicians, the American College of Physicians, Aledade, Agilon Health, Catalyst Health Network, ChenMed, Everside Health, MDVIP, Elation Health, Village Medical, and One Medical. So thank you to all of those organizations that have made this commitment and are joining us on this journey. We'll share a little more about Primary Care for America's goals later in this session. And now I'd like to introduce our first guests. Recently, the National Academies of Science, Engineering, and Medicine released a new report entitled Implementing High-Quality Primary Care, Rebuilding the Foundation of Healthcare. This report highlights that primary care is the only discipline of medicine where a greater supply is equated to better health outcomes, longer life expectancies, and lower costs. Today, we have two guests who served on the report committee for NASM to walk us through their findings. Dr. Asaf Bitton is an associate professor of medicine, Division of General Medicine at Brigham and Women's Hospital, and associate professor of healthcare policy at the Department of Healthcare Policy at Harvard Medical School. Dr. Bitton is the executive director of Ariadne Labs, a joint health system innovation center located at Brigham's and partnered with the Harvard T.H. Chan School of Public Health. Ariadne works to save lives and reduce suffering by creating scalable solutions that improve healthcare delivery at the most critical moments for people everywhere. Previously, Asaf led the primary care healthcare team at Ariadne and their efforts on the Primary Healthcare Performance Initiative, a joint effort with the Bill and Melinda Gates Foundation, the World Bank, the World Health Organization, and the Results for Development Institute. Thank you, Asaf. Dr. Molly Cooke, Professor of Medicine, is the inaugural Director of Education for the Global Health Sciences across the 5 schools at the University of California, San Francisco. That includes medicine, dentistry, pharmacy, nursing, and graduate division. Appointed in July of 2012, her charge is to develop a portfolio of high-impact educational programs for UCSF students, residents, fellows, postdocs, and faculty members, and to devise innovative and high-value ways to share UCSF's expertise in discovery science, healthcare delivery, professional education, and basic science with international partners. Thank you both for being here. I can't think of 2 people more qualified to discuss the findings with us. Asaf, I believe you're going to kick things off.
Thanks so much, Bill. It's great to see you. Thank you for the introduction, and I'm really happy to be with you all today. I just literally ran in the door from my clinical session seeing patients, and trying to convince those last few vaccine hesitant folks that it's okay and safe and wonderful to get the vaccine. It's great to be with you all today. We're going to run through this report, 414 pages in less than 24 minutes, and we will not be dry, and we will try to be interesting and provocative and welcome your questions, and really delighted to be here with you. I should just say at the outset that I serve as a senior advisor at CMMI for primary care work, but I am not representing any official CMMI or CMS views today. I'm speaking as an academic and a primary care physician. Next slide, please. We labored over this labor of love, Molly and I and the other committee members, for the last 18 months or so, and it obviously came at an important time in our history and health history, and we want to share the findings. And in the next slide, you can see that this was an unusually large committee for an unusually large task. In the next slide, we can see that we had a committee that was multidisciplinary by nature and practice, everyone from doctors, nurses, physician assistants, anthropologists, sociologists, people with experience in federal government, state government, leaders of community health centers, leaders of community health worker programs, dentists, and more. So we did our best within this small but mighty group to represent the diversity of perspectives that is and encompasses primary care across the US. And in the next slide, I'll show you really what we were tasked with doing. We were tasked with doing something different from the usual National Academies reports, because the focus was on implementation, and implementation in this critical moment, in this critical time in our health system's trajectory and development, and really implementation looking back across 25 years to the last Institute of Medicine report that was done on primary care, and asking the questions, what worked and what didn't work, and where do we need to look at for levers and stakeholders and action to inform the improvement of primary care systems. So this was not a recitation of evidence on why primary care is so beneficial, because that is an open and shut case. The evidence is strong, it's profound, it's in the US and it's outside the US, that, as Bill said, health systems that are built on a strong foundation of team-based integrated primary care produce better values at lower costs and with greater equity than those systems that are built on other foundations. And so our job was really to understand and to create an actionable implementation plan, looking at the implementation evidence from a variety of perspectives. Next slide, please. That means that we had to first, of course, start by looking in the context. And it's really important, and we did, this is the one area where we spent significant time really laying out the evidence of what Bill and now I'm telling you, that primary care not only is associated with beneficial health outcomes for communities and for individuals, but as a individual discipline, it's the only individual discipline. And I can tell you this because I was part of these studies. When you look at the supply of primary care, and you then look at the supply of hospitals, and you look at the supply of specialists down to a county level, primary care is the only part of the healthcare system where increasing access and supply to that part of the system is actually associated with county level, not just state level, but county level improvements in life expectancy, improvements in health outcomes, and improvements in equity. That's not to say, of course, that specialty care and acute hospital care are not critical. They are critical. You saw that in COVID, you see that every day. What it is to say is that this is a key part of the system that at the very moment that we need it most, it's weakening. And this is an empirical statement. It's not an ideological statement. It's not a statement for lobbying. It's a statement of empirical fact that there are both area level effects of having higher primary care, and that there are, and we found and documented throughout this report, numerous examples that we can build upon, that we can use across the US of systems, localities, and states that have had success at implementing high quality care, primary care. So the question before us was really, what are the underpinnings of that success, and how do we drive a sequential agenda with named actors to improve those outcomes across the US more substantially? Next slide, please. We know that at the moment in which we need the benefits of primary care most, not just at the health system outcome level, but the benefits of long-term healing relationships with individuals, families, and communities, we're actually spending less and less on primary care. So in this graph, you can see the proportion of visits to different parts of the healthcare system. Primary care sees as many visits as specialty care and is paid only 5% of total costs, or 1/3 less than specialty care, and you can see the imbalance, of course, with hospital care. And it's very important to look at then what the implications of this imbalance are. In Medicare, it's even a greater imbalance, where Medicare only pays about 2 to 3% of its total spend on primary care at the moment, when primary care as a locus of coordination, as a locus of integration across a fragmented system, as a locus of improving care that's inclusive of social determinants of health that actually drive overall health outcomes. Primary care is that central locus, but is being underfunded and underemphasized to do that work. Next slide, please. So as this share of total spending of primary care is low, what we've also found mapped over now 2 decades is that the total proportion of healthcare spend across any part of the healthcare system, whether it be federal, commercial, et cetera, is actually not just low, but it's decreasing. And at the same time, COVID not only amplified all of the known inequities that you've seen and read about and grappled with, but in particular, it exacerbated a particular shortage in access and crisis of care within primary care. We were doing national tracking studies throughout the pandemic, finding that at 1.5% of primary care practices were reporting in a national tracking study to have closed. 42% had furloughed workers, and 25% wondered whether they would keep open over the next 6 months. So again, at the time when it's needed most, it's coming under some of its greatest pressure, and we'll talk about some of the core causes of that pressure. Now, meaningful policy changes and practice changes occurred. You know about telehealth and its incredible rapid ascent into all of healthcare, not just primary care, but that's almost a Band-Aid for some of the deeper problems that this part of the system faces. Next slide, please. So in order to do this report, we had to update the definition. I know you're busy people, you don't have a lot of time for definitions, but here's what I want to point out. The definition of primary care is not just a service line, is not a clinic in a box, is somebody that you go to for simple problems, but actually is the provision of whole person. So mind, body, inclusive of dentistry, inclusive of eye care. So whole person integrated accessible care with a focus on equity that's provided by teams of interprofessionals that are accountable. They are accountable for addressing the majority of a person's health and wellness needs across their lifespan and across their community setting. And they do this through the creation, maintenance, and improvement of relationships. So I want you to think about whole person, team-based, relationship-centered care, not as buzzwords and not as nice to haves, but as actually what the evidence shows as the mechanisms through which primary care improves outcomes at lower costs and equity at the same time. Next slide, please. So given that, and given its uniquely valuable role across the healthcare system, the committee found that primary care can be thought of as a common social good, a part of the healthcare system that has high societal value across and amongst healthcare services. And at the same time of this high value, it faces a bit of the tragedy of the commons, where shares of investment and workforce challenges are making this key critical locus of integration, wellness, and health promotion acutely vulnerable, even before COVID, but certainly during and as we step into the next phases of COVID. So that requires attention on a public policy level, on an oversight, monitoring, and accountability level, as well as advocacy and leadership. But leadership and advocacy from an empiric basis, not from just a self-interested basis, because we know that everybody always says that their specialty and their part of the healthcare system is the most important. I think the argument here is that there's empirical evidence that primary care is uniquely poised and situated to drive key common convergent health policy goals across the healthcare network these days. Next slide, please. So given that, the committee was tasked with an implementation plan that takes a system view across macro, federal, and state policy level, across meso, hospital level, and across micro, clinic, and individual level actors. It was tasked with creating an accountability plan for that implementation, and we'll talk at the end about what that might look like. And it opened an aperture and shined a light on the idea of an important policy window that exists right now, given common population concern over the future of the US healthcare system, a concern that crosses the political aisle, and a common theory of the case around how COVID-19 has revealed certain weaknesses in and across the healthcare system, particularly in primary care, that must be addressed for future national health security. Next slide, please. So our 5 objectives, because we don't think you have the time to read a 414-page report, so it's our job to communicate to you 5 objectives and 5 top-line messages, and that's what we're going to do over the rest of the report. The top-line messages are in the area, and they are in order of action because one situates and creates the next, of payment, creating the fiscal space to improve access, improving access to multidisciplinary teams that are trained and available to take care of communities that then have the right digital health tools to provide healthcare in a 21st century manner and in a person-centered and consumerist manner, and then have an accountability framework for the named actors in these roles to be able to carry out these changes. Next slide, please. And so what we see, and if you take nothing else away from this report and this talk, it's these 5 ideas, that they're sequential and they interplay with each other to create high quality primary care. The evidence is strong for them. That was our task as a committee, to find policy relevant evidence. And more importantly, there's a sequential pathway through which named actors in these areas could actually achieve common goals. The first objective is to pay for primary care teams to care for people, not doctors to deliver services. So we're flipping around the ways that we pay for care to really pay for the things that we mean to create, as opposed to the idiosyncrasies that we've held in the past. The second top line item is to ensure that high quality primary care is available to everyone in every community. And we talk about ways that that might happen. The third is to train primary care teams where people live and work, then to design information technology that actually meets patient, family, and provider needs, and finally to ensure that there's a framework for implementation and accountability in the US. So we'll get started. I will talk about the payment angle, and then Molly will talk about the other 4 areas. So in the next slide, we talk about the payment recommendations, and in the next slide, what they really boil down to are 4 interrelated actions. Number 1, that we need to have a common consensus. The evidence is clear that the dissemination and evaluation of payment models, the creation of these payment models is really aimed to deliver high quality primary care and the benefits that derive thereof, not to deliver short-term cost savings. And this is a change from previous discussions over the past decade in which predicated on investments in primary care was the idea that they will lead to short-term cost savings through decreased hospital utilizations. What the committee found is that those cost savings take time to manifest, often through time windows that payers and federal policymakers have a hard time constructing, 5 to 10 to 15 years. But the evidence is clear that the better and more aligned payment models can generate cost neutrality while they generate better care, better outcomes, and higher equity. The second part then would be to build these payment models away from the current dominant fee-for-service widget-based system for paying for visits toward a hybrid reimbursement model in which increasing amounts of primary care payment are paid at the population prospective panel level, meaning that you pay prospectively for care to happen over time by a team as opposed to paying for visits by doctors in a clinic. That allows the flexibility for teams to do what they need to do to build, create, and maintain health in partnership with their patients, families, and communities. And for those primary care practices who are in risk-bearing contracts like ACOs, the committee also pointed out a key area of improvement, which is to make sure that payers ensure that sufficient resources and incentives are flowing in an aligned manner toward primary care within these risk-bearing contracts. Because a lot of times, ACOs, especially hospital-led ACOs, will enter in a total cost of care contract, which is a capitation mechanism, but then continue to pay internally fee-for-service for primary care, which distorts and obfuscates the incentive structure and the mechanism of action for actually achieving common risk-bearing contract goals. Next slide, please. Hybrid is, we talk a lot about that. You know, some people would say we need to move all to capitation, others say not. The key is the US is a heterogeneous healthcare system. To mandate or suggest that there's only one way to pay is a recipe for defeat. To suggest, where the evidence tells us to go, that a hybrid system that rebalances payment toward prospective payment that's risk adjusted allows primary care practices at different stages of maturity off of fee for service to move toward risk contracts and contracts that allow them to have the fiscal space to provide the care that they want to need. So what we take is a pragmatic stance to move the needle substantively toward substantive prospective population-based payment. Next slide, please. The last two actions, one action is really aimed at CMS to look at and increase the overall proportion of healthcare spending, which I said right now is at a low rate, even lower than the commercial market. So CMS spends 2 to 3% of its overall spend on primary care, 5% overall in the US. Most comparative high-performing countries that we see in the OECD network spend somewhere between 10 and 15%. So CMS should increase that overall proportion of primary care spending. It should do so as it's transitioning to hybrid prospective population-based payments by taking early steps to improve the Medicare physician fee schedule, to increase, again, services and reimbursement toward primary care, and doing so by taking the RUC, which is a committee that advises Medicare on a purely advisory basis on how to value services, make the RUC what it actually is, an advisory committee, and internalize some of its structures into CMS so that CMS can value physician fee schedule codes as it sees fit, take the RUC's input as they see fit, but then make decisions that are aligned with overall policy trajectories. And finally, at the state level, the committee found evidence to suggest that facilitating multi-payer collaboration, inclusive of federal, state, and commercial payers, to work on creating that supportive environment for hybrid payment models that increase the proportion of healthcare spending for primary care would be conducive with the overall goals of implementing high-quality primary care for all. With that, I'm going to hand the next slide over. Actually, there's one more slide, which is just to lay this out. Again, a transition away from full fee-for-service, the committee found extraordinarily strong evidence that fee-for-service is corrosive and misaligned with the overall goals of primary care service provision for the U.S. healthcare system, moving it toward a risk-adjusted capitation model predominantly with some residual fee-for-service, doing so with some of the revaluation techniques we talked about, and then moving those practices that are in risk-bearing contracts, again, to make sure that they have sufficient resources to do their work. With that, I'm going to hand over to Molly. Thank you.
So thank you so much. I hope can you hear me? I hope I'm not muted. Good. So great talk, and I'm so glad I didn't have to speak about payment. I appreciate the introduction that I got from Bill. I would also like to say that I have had the privilege of playing a leadership role in the ACP, and I'm so glad that they are a partner in this initiative. So I'm going to press on. Clearly, the committee was of one voice that the primary care is the foundation of a well-functioning healthcare system. And as Asaf already pointed out, there are several significant problems with how primary care is integrated into our healthcare system at this point, not least of which is the fact that not everyone has a primary care physician. So our first recommendation under the heading of ensuring that all people have high quality primary care available to them is that we need to ask beneficiaries to ensure or to identify that each of their enrollees has a source of primary care. And this is a absolutely critical issue. There are, as is well known, areas of real deficiency of availability of healthcare at all, and primary care in particular. So HHS should create new health centers, rural health clinics, and IHS facilities in shortage areas. Next slide, please. The committee also calls upon CMS to update its standards for primary care for Medicaid beneficiaries, and to make sure that states are able to accomplish this for their Medicaid members. As Asaf already mentioned, and I experienced this as a primary care physician myself, while COVID presented us with many challenges, it also helped us identify that there were changes, relaxation of standards that are beneficial. So in my practice, we are reimbursed for video visits in the same way that we are reimbursed for in-person visits. And many of my patients, certainly not all, but many of my patients do absolutely fine with the predominance of their visits being video visits. So this should be pressed forward so that we can continue to enhance access by allowing patients who don't need to be seen in person for a particular visit to be seen by video. The fifth action under this overall heading is that we need to do much, much better in involving communities and patients, families, and community-based organizations in the overall provision of our services. And this has been an interest of mine for a long time, and it has been consistently a weak link. And I'm an academic like Asaf, and so I will admit I live in an ivory tower, but we need to do a much, much better job engaging the communities, families, and people that we serve in the design of the services that we are providing. Next slide, please. So the next overarching recommendation, or maybe I would even, I'll say assertion of the NASM committee, was that absolutely primary care teams need to be trained in the communities where the people that they're serving live and work. And I'll go a little beyond the statement here and say, really, we ought to be being much more aggressive in recruiting clinicians from the communities where the service needs are. There's a lot of lip service given to this, and way less action. We really, really need to look at where the service needs are, and identifying ways to recruit and also support and promote trainees from those communities. Next slide, please. So this is really 3.1 is a reiteration of what I just said. We should be much more thoughtful about, much more thoughtful and much more active about building real pipelines from communities in need to the health workforce. I won't say healthcare, I'll say just overall health workforce. And internationally, there are some fantastic examples of this that are, from an American perspective, fairly mind-boggling in terms of allowing communities to promote high school graduate level people to a next step in training, having them come back, work in their communities, and then again having the community say, is this a person we want to see go on to a next level of training so they can come back and work with us again. It's a total shift in the level of control of who gets to be part of the health workforce. So I think we ought to look hard at that. There are many opportunities for the federal organizations and states to do a much better job promoting interprofessional training. I mean, a theme of the committee's work was the critical nature of team-based care. But in our educational system, training is not very team-based. And I live with this at UCSF, where we have 4 health professions schools, but they have different calendars and different schedules and different grading systems. And we really are not showing the power in a systematic way of effective team-based care, which is essential for primary care. Next slide, please. So the next element of our recommendations, and COVID really underlined this in some important ways, is that we need to design a whole information system infrastructure that supports patients, their families, communities, and the healthcare system. And a number of us work with electronic health resources that were designed for different reasons that patients find hard to use, that honestly clinicians find hard to use and burdensome, and that are not promoting the integrated care of patients in their communities that we want to see. So next slide, please. The ONC and CMS should develop maybe, I hate to say this, but maybe from the ground up, a whole new approach to digital health that support this relationship-based and person-centered care. It simplified the user, and I would again say as a clinician, the user and the clinician experience, and that support equitable access. Right now, what we have is a system that in some ways increases inequities. So this needs to be addressed, and again, I'll be maybe a little out there and say I think right now the vendors are sort of running the show, and we think that this is a service in the common good, and it ought to be working to make individuals and communities healthier. Number two, a comprehensive patient data system that can be used broadly to ensure that health in the country is getting better. Next slide, please. Next slide, please. So the final piece of this, and I actually think that this is key, since our charge was, all right, I'm watching the time. Our charge was not to entirely rethink primary care, which has been thought about and thought about and thought about for 40 plus years, but to make sure that that this actually, that the implementation steps occur. So next slide, please. We would like to
Molly,
yes.
Actually, it's Bill. I'm going to interrupt you and come back to have you and Asaf finish. I know that Representative Raja has got a time crunch, and I'm going to introduce him and then have him speak quickly, and then we'll come back to the slides. So thank you. Congressman Raja, thank you for joining us. As a means of introduction, Congressman Raja is a member of the Congressional Primary Care Caucus and represents the 8th District of Illinois, which includes Chicago's west and northwest suburbs. He serves on the House Permanent Select Committee on Intelligence, the Select Subcommittee on the Coronavirus Crisis, the Committee on Oversight and Reform, and is chairman of its subcommittee on Economic and Consumer Policy, vice chair of the LGBTQ and Equality Caucus, co-chair of the Congressional Asian Pacific American Caucus Immigration Task Force, and as an assistant whip for the Democratic Caucus. Thank you for being here, Congressman. I'll turn it over to you to share a few words, and I think with we can see why you don't have much time with all you're doing, and thank you very much for your service, sir. Congressman, the floor is yours.
No.
Okay, very good. I'm sorry, there's a little bit of a delay. It might be because the Russians are interrupting my transmission, which sometimes happens. So I apologize for that. I see that you folks are here today to put the health back in healthcare. I'm trying to take the con out of Congress and put some pro back in progress. And it's so nice to be with you. I should tell you that my wife is a physician. My brother is a physician. I obviously didn't get the memo in the family to go to medical school, but I am nonetheless very proud to be with you and to serve my constituents and to help get them access to high quality health care. And you folks are tremendous allies in that effort. I want to say a special thank you to AAFP, ACP, One Medical, the whole PC4A coalition. I want to say a special thank you to Dr. Cooke, Dr. Bitton, Dr. Fong, and of course, thank you to Bill for your kind introduction. I just want to make some very brief remarks. First of all, I'm so excited to be part of the Primary Care Caucus, and whatever I can do there to be of assistance, please let me know. But at this point in time, it's so important that we, for instance, pursue some of the common sense reforms that are helpful to family care physicians and to primary care physicians, making sure, for instance, that we don't stick to just Medicaid rates for everything, that we start to increase the reimbursement so that the number of graduate medical residency slots to continue to have a pipeline of well-trained physicians in your profession and others. That's crucial, especially now with the oncoming shortage of physicians and the existing shortage in rural areas and underserved areas. Finally, I just want to put a plug for a piece of legislation that I am the co-author of, and that is the Dr. Lorna Breen Act, which provides vital resources for medical professionals and frontline healthcare workers for the purpose of establishing and augmenting mental health and well-being programs. You all know this. The pandemic has taken an extremely high toll on you and your families, and it's led to an increase in burnout, anxiety, depression, and even, unfortunately, suicide among physician and other frontline healthcare workers. This problem of mental health issues in the physician and healthcare community existed before the pandemic, but the pandemic unfortunately exacerbated them. I'm proud that I was able to get $140 million in the American Rescue Plan for this purpose, but we need to extend that and make it a multi-year program and make sure everyone has access. All that being said, I just want to say thank you for everything that you do. It sounds like you have a wonderful program and excellent speakers, and I'm just glad to be the warm-up bag for whoever's following me. And I just close with my favorite saying, which is that yesterday is history, tomorrow is a mystery, but today is a gift. That's why we call it the present. I'm so honored and blessed to be with you here for just a few short minutes of your precious time to celebrate you and what you're doing for your patients, for your communities, and of course, our country. So God bless all of you, and thank you so much for having me.
Thank you very much for joining us. Thank you for the work you're doing on the Primary Care Caucus, and especially for the work you're doing for physician well-being. You're right. It's a significant issue, and we appreciate you co-authoring that bill.
Thank you so much. Take care.
Thank you. And Molly, will return to you on the fifth area of accountability. And you are muted.
Oh, I am muted.
You're open now.
Okay. So the accountability piece is key, and probably a place where earlier recommendations fell short. So we focused a lot on this. We recommend 5.1 that HHS create a Secretary's Council on Primary Care to really focus on primary care as the foundation of a well-functioning healthcare system, ensure adequate resources, report to Congress, and collect input. Next slide, please. HHS should form an Office of Primary Care Research. So this is actually a huge issue, but there is a sense that I ran to in my ACP leadership role that primary care is simple, and specialty and subspecialty, I mean, primary care is really a specialty, but so I'll say subspecialty care is complicated and needs the investment of resources. But I find myself saying all the time to our fellows and residents, here's a practice habit, but there's really no research underlying it. And as Asaf already pointed out, the disparity between patient care visits and patient problems and invested resources is striking. We really need to have high quality research underlying the work that we do, and we need good support for ARC. And we recommend that people, philanthropies, professional societies, and so on, pay a lot more attention to success, to best practices in implementing high quality primary care. We can all learn a lot from each other. Next slide, please. And we recommend that a scorecard be developed. There was a bunch of conversation about this because we are all subject to a lot of metrics. Many measurements actually add to burden and don't improve outcomes for patients. So we would like to see scorecard measures that are already available. They're simple, they make sense to people, and they build on data that are already collected and don't require another deep dive into patient records. So this is the last slide. Next slide, please. This is a summary. So our objectives, next slide, please, are that primary care teams be paid for the care they deliver to people, not for clinicians delivering services. They ensure that everyone gets primary care. Everyone has access to primary care. It's critically important that people come from and are trained in communities that particularly need good health care, that digital health services support individuals, families, communities, and their care teams, and that there are accountability mechanisms built through the system. So that's the basic top line recommendations from this National Academy of Sciences, Engineering, and Medicine committee that Asaf and I and a number of other wonderful people from various walks of health were privileged to serve on. So thank you very much.
Asaf and Molly, thank you so much for sharing this fantastic information and really in such a digestible form. The work that went into this by the two of you, I'm sure, was tremendous. And as a primary care physician that represents many primary care physicians, I thank you for this. I will take away from you, I'll steal the term if I can, that fee for service is corrosive. And I'm going to run with that one if you don't mind. Again, thank you so much for the work you put into this and for sharing this report with us today. And then I think next I'm going to pass on to Kaina, who will share a bit more information about Primary Care for America. Kaina is the CEO and co-founder of Elation Health. Elation Health is proud to also be a founding member of Primary Care for America, and I have the honor today to introduce her in what she's doing for this important collaboration. So Kaina, the floor is yours.
Oops. Sorry, I think I was muted. Thanks so much, Bill. Are the slides coming up? Awesome, fantastic. So my name is Kina Fong. I'm the CEO and co-founder of Elation Health, the technology platform for independent primary care in the US. So our mission is to strengthen the relationship between primary care providers and their patients, which we've seen in today's presentation has such a powerful impact. So Elation Health is proud to be a founding member of Primary Care for America, and I have the honor today to share more with you about this really important collaboration. As Bill shared at the beginning of this session, Primary Care for America is a diverse coalition of key partners focused on educating policymakers and health policy influencers about the value of comprehensive, continuous, and coordinated primary care. So in today's brief session, I'd love to share a little bit more detail about why we formed Primary Care for America. So as you guys have seen, the information shared today by Dr. Bitton and Dr. Cooke really isn't new. There is and has been a preponderance of evidence that's truly decades old about the benefit that primary care can have on individuals' health. Yet we spend only 5% of our healthcare dollar on primary care, while most developed countries spend more than double that. And even worse, despite spending twice as much on healthcare on a per person basis, people in the US have worse health outcomes for most conditions than their peers in many developed nations, you name it. Australia, Canada, France, New Zealand, the UK. The COVID-19 pandemic has exposed the flaws and limitations of our current healthcare system and its impact on patients, expanding gaps in patient access and health quality. And it is truly past time that patients receive the healthcare system they deserve, one that prioritizes their health above all else. And unfortunately, that's not true today. For decades, our primary care physicians have experienced firsthand the limitations of our current healthcare system and its challenges for patients, and yet the critical role of primary care to deliver comprehensive healthcare for everyone in America is every day undervalued and underrepresented. So we're here to say it's time for this to change. Next slide. So our mandate is clear. It's to deliver a healthcare system that prioritizes America's health. As shared by our colleagues, it's time we prioritize and elevate primary care physicians and the critical role they play in delivering comprehensive, patient-centered healthcare. As we all just saw, last month's study from NASM had the remarkable conclusion that primary care is the only discipline of medicine where a greater supply is equated to improved population health, longer lives, and greater equity. Primary care providers operate on the front lines of healthcare, and they're uniquely positioned to serve as the keystone of a modernized, high-functioning healthcare system that enhances patient care and reduces healthcare costs. We often forget this, but primary care clinicians and care teams are often the first line of defense in not only managing chronic disease, but also identifying and diagnosing mental health illness and reinforcing public health activities. Yet again, their critical role has historically been under-prioritized and under-resourced. So building on NASM's report recommendations, Primary Care for America has outlined the following 5 guiding principles to help transform primary care in the US. So the first is we must improve access to comprehensive and continuous primary care for patients in underserved communities by removing barriers to care. Second, we must restore growth in the primary care workforce to ensure effective and accessible care for future generations. Third, our health system must prioritize the role of primary care teams in promoting patient health and wellness instead of the current fee-for-service framework, as we've spoken about earlier in this session, that narrowly incentivizes sick care. Fourth, the primary care infrastructure must allow for flexibility and innovation to meet individual community needs. And finally, more resources must be allocated to primary care with an increased focus on comprehensiveness of care. Next slide. As we look to influence and affect change, at Primary Care for America, we've outlined very specific and intentional goals to guide our efforts and lead us to our North Star, which is develop a system that invests in the true care of health and values an integrated approach coordinated through primary care. So here on the slide, you'll see our immediate impact goals are to demonstrate the value of primary care, increase the investment in primary care, drive innovation in primary care and payment design, and truly position primary care as a solution to major policy challenges. Secondarily, we also seek to grow the primary care workforce, prioritize primary care and benefit design, and create a competitive marketplace for primary care practitioners. Next slide. So our goal at Primary Care for America is to position primary care as the foundation for a sustainable future for American healthcare. Our goal is to educate policymakers, their constituents, and influencers on the collective value and understanding of primary care to ensure legislative and regulatory action. We're committed to achieving the following: improved patient outcomes, reduced healthcare costs, increased innovation, and workforce transformation. And we're very excited to introduce Primary Care for America today. Next slide. So on behalf of Bill, myself, Elation Health, and all of the Primary Care for America partners, we'd like to express our appreciation to today's presenters, as well as all of you who are sharing your afternoon with us to discuss the critical need to reposition primary care as a foundation for America's healthcare system. We'll hope you'll join us at Primary Care for America and follow along as we continue to advance these critical healthcare priorities. Thank you so much.